peaks 48 to 72 hours after the injury. This edema results in an increase in brain tissue volume, carrying the potential for increased intracranial pressure, or ICP. The extent and severity of the injury are factors that determine the degree of cerebral edema. Anatomically, the skull is an empty cavity with 3 rigid sides containing blood, brain, and cerebral spinal fluid. These components exert pressure on the skull. This intracranial pressure is normally 0 to 15 millimeters of mercury and is maintained by rapid alterations among the components throughout the day. Increased ICP is a life-threatening event that results from an increase in pressure in any or all of the 3 components within the skull. Let's take a close look at the assessment of a child with a head injury. The initial assessment consists of the ABCs: airway, breathing, circulation, spinal cord injury, presence of shock, and a neurological exam. During the neurological exam, you'll assess the level of consciousness. Did the child lose consciousness at time of injury? Pupillary symmetry and reaction to light, any retinal hemorrhages, seizures, or memory loss. Next, you'll examine the scalp for lacerations, palpate for depressed skull fracture, widely spaced sutures, and the size and tension of fontanelles. Inspect for bleeding or drainage from the nose, mouth, or auditory canals, and test any drainage present for glucose. Ongoing assessment includes assessing level of consciousness and observing for signs of increased ICP. Early, there would be irritability, restlessness, anorexia, and headache. Intermediate signs are projectile vomiting, sluggish, unequal pupillary responses, papilledema, blurred or double vision, bradycardia, hypertension, and seizures. And late, alterations in level of consciousness, decreased reflexes, decreased respirations, hyperthermia, herniation of the optic disc, and decerebrate posture. You'd also assess for signs of epidural and subdural hemorrhage. Diagnostic tests such as a CT scan, MRI, or skull radiography are likely to be ordered. Now, what about your nursing care? Basically, it's bed rest and continued observation, with a clear liquid diet if the child is conscious, and IV therapy if unconscious or unable to tolerate oral fluids. You'd monitor neurological status, level of consciousness, pupil response, symmetry of movement, vital signs, and signs of increased ICP. You'll decrease environmental stimuli, elevate the head of the bed 30 degrees, maintain NPO, followed by progressive diet as ordered and tolerated. You'll monitor intake and output accurately and often, and weigh the child daily. In addition, you'll take seizure precautions, collaborate with the parents in evaluating the child's behavior, and encourage family support and involvement in the child's care. Surgery might be done to decrease pressure and remove bone fragments, and continuous ICP monitoring is another possibility. Drug therapy might involve antiepileptics to prevent seizing, corticosteroids to reduce swelling, osmotic diuretics to reduce brain volume and decrease intracranial pressure, sedatives and analgesics for pain management and to decrease metabolic demand, and antibiotics to prevent infection. What about home management? If the child has a mild to moderate concussion with no loss of consciousness, you'll teach parents to check the child's level of consciousness every 2 hours, maintain contact with the healthcare provider, and return to the healthcare provider within 1 to 2 days for a recheck. Remember, signs of epidural hematoma generally appear 24 or more hours after the injury, so you'd provide written instructions for parents as well as appropriate contact numbers in case of emergency. Advise parents to use automobile seat belts and safety seats properly, and helmets when appropriate, such as when the child is bicycling, playing sports, and riding scooters and skateboards. Another preventable type of head injury is called shaken baby syndrome. Healthcare providers suspect shaken baby syndrome when an infant less than 1 year old has subdural and/or retinal hemorrhages in the absence of external signs of trauma. Prevention is the cornerstone of your teaching. Make sure parents understand that they must never shake a child as a method of burping or waking an infant. Toss an infant in the air or shake the infant when feeling upset or angry. Now, let's do a brief review of another common pediatric problem, strabismus. It is a misalignment or deviation of the eye resulting from muscle imbalance or paralysis, poor vision, or a congenital defect. This condition is sometimes described as cross-eye, squint, or lazy eye. By the age of 3 to 4 months, infants normally achieve binocularity, the ability to simultaneously fix both eyes on one visual field. But with strabismus, one eye deviates from the point of fixation. If this condition is not detected or corrected by 4 to 6 years of age, a serious visual impairment known as amblyopia can develop as the deviating eye loses vision from disuse. Signs and symptoms of strabismus include frowning or squinting the eyelids together, closing one eye to see or tilting the head to one side, having difficulty focusing from one distance to another, demonstrating inaccurate judgment when picking up objects, having photophobia, dizziness or headaches, being unable to see, print, or moving objects clearly, and appearing cross-eyed. Strabismus is diagnosed with the cover-uncover test and the corneal light reflex. The cover-uncover test interrupts the fusion reflex, which normally keeps the eyes parallel. When one eye is covered, the other should remain in a fixed position, focused straight ahead. If it moves to establish focus, there is a deviation in alignment of the eyes due to muscle weakness. For the corneal light reflex, the examiner shines a light at the cornea and watches how the light is reflected. Normally, the corneal light reflexes just slightly towards the nose from the center of each cornea. If the light is reflected lateral to the center, that eye is deviated nasally. If it is reflected more toward the nose than normal, that eye is deviated laterally. How the client is treated depends on the cause of strabismus. It might be occlusion therapy, which is patching the stronger eye, and eye exercises for the affected eye. Treatment might mean surgery to increase visual stimulation to the weaker eye and/or to shorten eye muscles. Also, the child might be evaluated for associated neurological conditions like a brain tumor. What are your nursing care considerations? Parent teaching is important, including the eye exercises and occlusion therapy, using books with large print and wide spacing, providing bright lighting, and watching for signs of eye strain. Be sure to suggest creative ways to ensure compliance with therapy. School nurses assume major responsibility for vision screening, not only for acuity problems, but for other ocular problems as well. When a referral is made for further vision testing for a child, the school nurse would later follow up with the parents to make sure it was done. Attention Deficit Hyperactivity Disorder, or ADHD, refers to a group of related chronic neurobiologic disorders characterized by deficits in a child's ability to regulate activity level, that's hyperactivity, inhibit behavior, that's impulsiveness, and attend to tasks, that's inattention, in ways appropriate for age and developmental stage. ADHD can affect every aspect of the child's life, including home and school, and within family and peer relationships. These children are unable to sit still or pay attention in class and subsequently experience the negative consequences of such behavior. They experience rejection by adults and peers, and in response typically engage in a broad array of maladaptive behaviors. Repeated exposure to negative feedback adversely affects development of self-concept. ADHD has long-term adverse effects on academic performance, vocational success, and social-emotional development. As they grow older, children who have ADHD that have not been treated, in combination with conduct disorders, often engage in drug abuse and antisocial behavior. For many, the negative impact of ADHD continues on into adulthood. ADHD is the most commonly diagnosed disorder of childhood, affecting approximately 3 to